Even though it's infrainguinal by strict anatomic definition of the common femoral artery, a lot of times you have to worry about more proximal disease, such as, of course, the iliac system. So,
Hello, everyone. Thank you for joining us today in another recording at MurmurMD. My name is Sameh Sayfo, interventional cardiologist coming from Dallas, Texas. I'm honored to have a friend of mine, a colleague, and someone I look up to learning what to do the best way and the best technology. Dr. Nek Mouawad is a vascular surgeon. Thank you, Nek, for joining us today.
hey, thanks, Sam. It's so good to see you. I really appreciate the invitation and the opportunity to be here.
Absolutely. So, Nick, you take many hats. You are the chief of vascular endovascular surgery and the chair of Department of Surgery at the McLaren Health at Bay City, Michigan. But you're a busy, man. You do a lot of research. You're the chair of a cardiovascular research institute there. You're involved in many national, international studies, including arterial and venous. And we're really happy to have you today. We want to get your input on a very important topic that I think the technology we have now has really changed the way we look at it. First of all, thank you for joining us today. And for the audience, the topic today is about common femoral artery intervention.
Oh yeah, this is a hot topic, as you know, Sam. As you know, with peripheral arterial disease, a lot of times we're starting to challenge the status quo, things that are tried, tested, and true, and have remained the gold standard for many, many years. There are new opportunities, new innovations, new techniques, and I think it's important that we remain at the forefront of that. Of course, a fabulous operator such as yourself, we can challenge what's going on currently, and we should, like I said, keep ourselves abreast of what may and may not be the way forward in peripheral arterial disease.
So let's start with this. Common femoral artery, the way we look at it, if you talk to the trainee, you talk to physician, the gold standard for common femoral artery intervention has been surgery. Common femoral endarterectomy has been there for years, great outcomes. But before we go there, tell us, when do you start thinking this patient with common femoral artery disease require an intervention, regardless what the intervention is? What's the indication for an intervention?
Yeah, so let's start by my first disclosure. I'm a vascular surgeon, so these are one of those things that you don't mess with, you don't touch. The common femoral artery is a surgical reconstruction bed, or has been at least for eons, since the beginning of time, if you will. And so it's very interesting that we're discussing this, because I think it's important that we talk about this, about the interventions and the options moving forward. But yes. Similarly, regardless of the type of intervention, again, for common femoral artery disease, really the indications are similar, of course. Either lifestyle limiting claudication, or that's disabling claudication, which tends to be more common, as you see, in more inflow type disease. And of course, whether you have chronic limb-threatening ischemia or critical limb ischemia, those are those are the indications for intervention. Of course, it's the inflow to the profunda, which is, as we know, the lifeline of the leg. And so sometimes, in order to manage that inflow, it's very important to have a good flow from the common femoral artery. So I think the indications are similar as any other patient that would require peripheral arterial disease intervention.
From a workup perspective, do you think an arterial ultrasound is sufficient in this era, or do you think a CT scan play a role in deciding which pathway you take, what type of surgery you need to do? Because my understanding, I'm not a surgeon, but my understanding, common femoral artery surgery is not just one type of surgeries. It's different technique, a different product that you use for surgical options. Is CT important?
I think CT is probably going to be more beneficial, if you will, because even though it's infrainguinal by strict anatomic definition of the common femoral artery, a lot of times you have to worry about more proximal disease, such as, of course, the iliac system. So, a lot of times, at least we see nowadays, that have isolated common femoral artery disease just on its own is not as common as having common femoral artery disease with more proximal disease that might require a hybrid approach, maybe common femoral endarterectomy with retrograde stenting or angioplasty or something. So I believe having more anatomic detail with CT is probably more beneficial. In another fashion too is, a lot of times you might have significant common femoral artery disease, but you may have disease distally. And, the real tenet for critical ischemia is you want to have inline flow to the wound, particularly if you believe in angiosomes. So I think you want to know all that before you get in there, because you might do a femoral artery reconstruction and then realize you have, occlusion distally that they maybe need a bypass for. So you don't want to kind of put yourself in a position where you have to get into a redo groin type situation. So for us, I think, more anatomic detail would probably be best.
And when you have, for the audience who doesn't do surgery, now with the hybrid OR, do you do most of your common femoral in a hybrid OR, maybe because you may need to do a distal vessel intervention percutaneously at the same time? Is that something you think it's important if you see multi-level disease?
I do. I mean, I think, we have the luxury now. We work in a hybrid OR, and I think the luxury is to use that as much as possible. Whether you want to do, let's say, open endarterectomy, let's say, with something surgical distally, or if you want to do a hybrid approach, maybe clear up the common femoral artery, then come integrate and do something endovascular down the leg. I think having that flexibility I think is very important, and I don't see a reason not to do it in a hybrid OR if that is available to you. Is it absolutely mandatory? Probably not. But of course, as you know, the more imaging, I think, sets you up more for success.
Common femoral, we just discussed more of a chronic, slowly build up PAD with the common femoral involvement. From a surgical perspective, before we move to the endovascular pathway, can you elaborate to the audience, for both surgeon and non-surgeon, from a surgical technique, what's the difference when you go in for acute limb that with a common femoral occlusion, or maybe post per-close or post closure device, not per-close specifically, but any closure device,
Yeah.
or post manual pressure, versus when you have what you just mentioned, someone with CLTI or someone with a chronic claudication? What's the technical differences between the two procedures?
Of course, with an acute limb situation, whether it's a percutaneous closure, failure, or complication, it's a little bit different. Of course, the leg doesn't have as much time or the luxury of time for that type of ischemia, and usually the artery tends to be not as diseased as one may think, particularly if it's embolic from AFib or something along those lines. So it's easier to manage the artery. In the more advanced peripheral arterial disease, the CLTI, you expect more difficulty with clamping. You may have to go more proximal clamping. You may need a hybrid technique for balloon occlusion proximally in order to get the management of that. And of course, those endarterectomies tend to be generally more extensive. They tend to involve primarily the profundo or the bifurcation. So I think technically it is a little bit more challenging. And in more complex PAD or CLTI, you almost always have to do an endarterectomy with a patch reconstruction. For the acute ones, if you're lucky and it's just an embolus, technique is different. You need to just do, a transverse arteriotomy with really a primary repair of the vessel, because you don't have to worry about an extensive endarterectomy, if you will, or if you have to repair a closure problem. So I think the techniques, the exposure is the same. But the ultimate reconstruction may be different, because one you have to reconstruct and one you're just essentially repairing, which I don't want to jinx myself or anybody and say it's easier, but sometimes it's not as involved. Other times it's way more involved.
When we say easier, I think it's a very important word. I think because the amount of procedure that vascular surgeon they do, and the complexity, if you talk about a aorta bifem or fempop or below the knee, common femoral endarterectomy has been considered easier. But what are kind of complication? What are the things that you look for, that you're worried about when you do common femoral endarterectomy? What are the
Yeah,
things
I
that
think I think, I'm gonna kick myself here, but easy is such a not a term any vascular surgeon ever wants to use, because you're always like, oh, I'll go in there and it'll be easy, we'll be done in a few minutes, and next thing you know, it's some sort of massive reconstruction and the artery's breaking and you're tearing and there's no integrity to it, and now you're reconstructing it and it fails. Now you got to do a bypass, and so I think I will caution myself probably for saying easy, but as with any type of surgery. There are obviously a variety of complications that can occur, but particularly in the groin, the groin area, there's flexion there. It can, be sweaty and so forth. So there's, breakdown. There's dehiscence of the wound, which can be frustrating. Hemorrhage and infection, lymphatic leaks can be very challenging at times. Some people don't want to work very well with therapy post-surgery because, again, it's at the groin crease, so it's difficult to get up and out of bed. Of course, you want to make sure there's appropriate hygiene. So there's a variety of things that go on there. They say you don't see, let's say, for a brachial exposure. if you will. It's more exposed to air. It's, again, cleaner, if you will. And of course, the concern is, of course, after doing, an endarterectomy or a patch, redo interventions, redo access can be a problem sometimes. There's a lot more scars. So, a variety of things come into that. But that, of course, is, I would say, minimal in comparison to the durability of a open reconstruction, with patch.
What are the type of patients that you be worried about performing a surgical endarterectomy? What are the patient population that you expect complication and you wish, and maybe
Yeah,
now?
so I guess all our patients, they're the people with poor arterial integrity. Well, primarily, all joking aside, the people that we generally see, diabetics, obesity, overweight, panis. Particularly a lot of these people have had multiple interventions in that groin for access to other areas. Frankly, a lot of them that you will see as well. There are patients that have coronary artery disease, and they may have had access from the groin to multiple access sites, closure devices, scar there. These are the ones you tend to worry about. But I think other than issues of, let's say, leg ischemia, I think what we worry about, of course, is a groin complication, so dehiscence infection. Those can be very challenging if you get a pseudoaneurysm or an infection in the patch of the vessel. Those can be very, very challenging because a patch blowout can be life-threatening with a fatal hemorrhage, and a lot of times you want to reconstruct that. You may need a prosthetic because they don't have good enough vein. You can't use it in an infected field. So there are things. Again, these are fortunately not very common, but when they do occur, they can be quite dramatic. And avoiding them altogether is something I think all of us would like, if at all
Yeah,
possible.
you're absolutely right. I mean, I think the fact that our patients are getting more complicated, more comorbidity, more higher BMIs, older patients now coming in expecting treatment, invasive or endovascularly, either percutaneously or surgically. So you've been in the front line of many of the new devices. Biggest concerns when initially endovascular therapy for common femoral artery was, you go in, you do a balloon angioplasty or atherectomy, and you end up having a dissection.
Yeah.
European have had many studies showed benefit or durability of stenting, but it's still ideally that's an area you want to avoid stent as much as possible. So talk me through when you got introduced to some of the technologies, and I'm not going to specific what technology in mind because maybe you do something different than I do. What are the criteria of the technology that you hoped for, and maybe we have now that made you say, maybe I consider a certain patient to be endovascular?
Yeah, I think you bring up a great point. I think it's important, again, to stay at the forefront of all this. The Europeans have really spearheaded this, I think, with the management of common femoral artery disease. I'll start by saying that I think it's important to first identify the area and level of disease. I think, the Ozema classifications, a lot of the ones that we use, whether it's iliofemoral disease or isolated common femoral disease without bifurcation disease. Bifurcation disease tends to be a little bit more challenging. We can discuss some of the newer techniques, particularly from Europe, that discuss that. And you're exactly right. I think the biggest fear is, balloon angioplasty, the common femoral artery. You dissect it. Now you take out the whole leg and you take out the profunda, which is really problematic and can put you into an acute limb situation that can be very challenging. For us nowadays, as you had said, the patients are older. They need more work. And for us, I think the people use this hostile groin a lot. I mean, all groins, well, not all groins, but a lot of groins can be considered hostile. So I think we use that term very easily. But for us, let's just say you got significant inflow disease in the iliac and it tends to spill over into the common femoral artery, at least the proximal or mid-common femoral artery. Those type of patients, we would consider treating them in conjunction with their iliac inflow disease with, newer techniques. I think the biggest I don't say benefit, but the biggest buzz now, I think, is primarily these vessels tend to be severely calcified, and I think the use of intravascular lithotripsy has kind of changed the game. I think we had used previously atherectomy sometimes for that. Sometimes you have more distal disease in the SFA and popliteal. You can't get there because of the severe disease of the common femoral artery. So you want to create a channel. But I think nowadays, with the advent of IVL, I think that really gives you a good opportunity to really help modify the plaque, whether it's intimal or medial, and at that point really get you that luminal gain to at least get the patient out of their severe claudication or help as an inflow vessel now for the management of their CLI.
Um, when you look at the common femoral, I think the most common, I'm gonna call it a mistake, but things that we're learning now that we did not appreciate before is how big common femorals are. When you do endovascular therapy for common femoral, how often do you use the intravascular ultrasound, and is it, if any, use or help?
Yeah, so we've moved to using IVUS for a lot of our arterial interventions. It's really kind of changed the game for us to now, one, basically identify the pathology, confirm the pathology, and assist with resizing. And I agree with you. I think we tend to generally underestimate the size of the common femoral artery, just as like we did, or just like we do when it comes to tibials. We just did a common femoral artery intervention just last week, and the vessel measured 9.1 common femoral artery, and it was super, unexpected because the iliac you thought was like 8, and then and so you would obviously grossly undersized all that, and it was on IVUS. I mean, we checked it several times, and it was in fact that size. So I think it's important. You don't want to shortchange yourself, as any reduction in radius or diameter will severely affect your hemodynamics, and so you really want to make sure that you're at the appropriate size. I think using these advanced technologies is important. I think consideration, nowadays, even for calcification, calcium modification, debulking particularly, I think will help you. I think ultimately get better results. To touch on what you brought up, Sam, though, a bit, again, the Europeans have really showed that in order to really derive benefit from the common femoral artery intervention, they see it primarily with stenting. So they've considered a lot of newer techniques such as stenting the common femoral artery proper, or T stenting into the bifurcation lesions, or culotte technique, or I think Griffith and Nasser had come up with a trifle technique as well, with kind of really putting a self-expanding stent in the common femoral artery and putting balloon expandable stents in the SFA ostium and profundus. They have a variety of interesting techniques there to manage more complicated disease, which is primarily bifurcation disease. But I think outside of stenting, the data hasn't been as forthcoming. We'll see what the IVL stuff shows, even though I'm not sure. Is it off label? I think it may be off label. I'm not sure. I'm not
No,
sure if
it's
it
actually
is.
not off. It's not
Yeah,
off label.
I don't think
It's
it's
not
off
off
label.
label. They consider it a femoral artery because till
Yeah,
AUC change, it's still considered femoral artery.
yeah,
So
you're
our
right.
our hospital, you might be aware of, our hospital, we have started a single hospital investigative trials, a project of mine that I started 2 years ago of uh, IVL DCB versus surgery, and was
Nice.
something that we wanted to do because we don't have the data. And one of the things we learned early, we started when M5 Plus was the only device we have, and IVUS is mandatory for our endovascular cases. And we started noticing that, I'm
Too small.
putting 8 millimeter M5 Plus and I'm still
Yeah,
small. I mean, the
small. Yeah, too
recommendation
small.
was, yeah, 1.1 to 1. So tell me, you were one of the earliest adapter of L6. You're a big fan of L6. For the audience who doesn't know what the difference between M5 Plus and L6, in a short version, can you describe to us what's the difference? When would you use one versus the other?
Yeah, sure. The L6 really primarily comes up to, and we're referring to basically the shockwave technology here, which is the larger devices, 8, 9, 10, and 12. And it has, it's a 30 millimeter device, and it has a uniform use of the lithotripsy shockwave. So if you look at the way the shockwave comes out, it's actually uniform along all 3 centimeters, which is different than the M5 Plus, which has a higher amplitude in the mid portion and a little bit lower at the ends. It's over an 018 platform, and again, it gives you those larger sizes. And we've been very happy using that, particularly because of the significant aorta iliac disease that we see that's calcified, but now have kind of moved on to consideration for it primarily for common femoral artery, again, because the vessel is larger than we anticipated, and we confirmed that with IVUS. So we tend to use that to get our luminal gain. if we're treating this in an endovascular approach and not surgical.
And
But let me
from
ask you, Sam, a real quick question. Since obviously you're spearheading this in this trial as well. So how are you? Is it just one-to-one randomization? How are you guys picking who gets endo versus open, or is it just literally one-to-one? Because that
okay.
I think that's always a challenge for who should we have an endo and who should we do open surgery on? It's always a good topic to talk about.
So yeah, no, it's a very difficult, and I think we changed the design of the study multiple times. We in the study in the sub investigators and the national investigators, we have two vascular surgeons. You know both of them, Dr. Mazin Fote and John
Yeah,
Cadora.
yeah,
And what we made it is one of the inclusion criteria is it has to be reviewed by the interventional cardiologist and has to be reviewed by the vascular surgeon, and both should agree that this common femoral is doable in both ways. Can be
yeah.
surgical, can be femoral, can be endovascularly. It has to have moderate severe calcification. We didn't specify if it has to be just common femoral. Now there's a new classification they called Rapolino classification. Look at type A, 1, 2, 3, which is basically what you mentioned, involving the iliac versus just common femoral versus the bifurcation. And for certain patient where the patient was not a surgical candidate, we actually excluded those patients. We want to make sure we're really comparing apple to apple and vice versa. So it's very important when you do a study like this to not be biased one way or the other, because if you just say low risk patient go for endovascular therapy, or high risk patient you go to surgery, you end up having a biased study.
Right. I
It's
agree.
exciting. It's something we've been working on. It's a kind of pilot study because I think the future is bright. We have phenomenal operators across the country who has, like yourself, who's been working on this, has been showing it that it's doable, but we still don't know which patients. And I think a conversation like today hopefully can shed the light and can open this conversation to a wider range. We're still limited, if, for example, you just mentioned this, for the study, it's IVUS guided IVL plus DCB. And the largest DCB we have is 7 millimeter.
You're right.
So if I'm doing an
I was just about to say, it's like that's a challenge because the largest DCP is 7 millimeters, and so you're not going to be able to get that anti-restenotic therapy coating the wall if the common femoral artery is bigger than that, which again is I don't know if it's surprising, but it's bigger than it's bigger than you think, especially when you look at it on IVUS.
I think if you really want to, we learned in the coronary world, every study that failed comparing PCI to CABG and the CABG win is because PCI does not, when attempting PCI or doing PCI, we're not really achieving what surgery has done. For surgery for bypass, you really need to achieve the most amount of intervention, or every vessel to be open. In peripheral, you can have halfway done. Like you can't go and say, well, this is common femoral surgery, cleaning the endarterectomy, cleaning the blockage completely, where you coming in and show going from 100% to 50%. It's not apple to apple. So I think having an IVL of 8, 9, 10, 12, I think it's very helpful. We haven't used 12 yet in the study, but hopefully we don't use that. But I think it is a challenge, absolutely. The other thing is, what other future technology you think? Like, for example, you've used a serration balloon, the Maximus 6. Do you think there's a role for similar technology in a larger size or larger DCB, or any different type of atherectomy would you use here?
Yeah, I think so. I mean, again, the goal here is to really achieve that luminal gain. I mean, the challenge, I think the future primarily is going to be with IVL because most times they're severely calcified in those vessels. I mean, we do see mixed morphology plaque or plaque based, of course, when you do it surgically, but they're just really hard to cross. And I think depending what your choice of atherectomy, to get that luminal gain, I think is beneficial. For us, usually it's as a step up to allow access to the infrainguinal vessel, if you mean like SFA or POP. But if for an isolated one on its own, I think again for us primarily it would be usually tends to be IVL, and unfortunately we just we don't have a DCB that's big enough. But not opposed to considering something else if it's available. I must say that for us, outside of patient risk factors or redo groins, et cetera, we still tend to look at common femoral artery endarterectomy. But I think similarly to you, the patient population we see tend to be much more complicated, and it's really unusual to have isolated just, let's say, mid-common femoral artery disease. There's usually some over spillover, a severe profunda disease that might require profundoplasty. So that's the type of patient we generally tend to see.